And good afternoon. I'm Dr. Ara Jukmajan, CEO and founder of the Duke Spine Institute. We're going to be performing endoscopic spine surgery on a patient from Oklahoma who presents to us with how many years of back pain?
6 to 7 months.
All right. So she hurt her back, threw it out about 6 to 7 months ago. She saw doctors in Oklahoma. They were not able to help her. Some of them even went so far as to tell her that her pain was in her head, which is really unfair to say that to a patient suffering with chronic pain. And she found Duke Spine Institute. Is she reliable? She saw that we could cure back pain, and she's here for a curative procedure. All right, looks perfect. The first disc I always approach is the hardest, and the reason for that, for those of you diehard fans of mine, know why. If you get the first hardest disc needle placed, which is the hardest to place, then you can make an incision. You can introduce the second and third or fourth needles through that incision, and you should be able to access the easier disc through that incision. But the entry point in the skin where you go in is very important to being able to successfully get to the hardest disc to get to, which is almost always the L3-S1. So if the L3-S1 is the hardest disc to get to, I may have to start here, I may have to start here, I may have to start here or here, and anywhere in that circle. So let's show them the circle. Your entry point is the point where the needle enters the skin. We call it the entry point. And your entry point for this procedure could be anywhere in this circle. Okay? That circle represents a safe area to enter. However, being able to navigate past the nerve root and the facet joint and achieve the proper angle of attack to the annular tear really is determined by your entry point. So I have to find the best entry point for each disc herniation on each patient with different anatomy. Once you get that best entry point for the hardest disc to achieve, that sets the entry point for the other needles, usually. So that's why that I always do that first. But we're just about in at 5-1. How is she? So should I wait a little bit, or is she good?
Okay, we're going to ask you a few questions, okay?
All right. You think she's ready?
Yes.
All right. So you can see, let's just look at the x-ray picture. The tip of our needle, we call it a spinal needle, it's 18 gauge. Show us the facet joint I went past. Facet. It's behind that, the facet joint. Yeah, so start your arrow and go backwards now. For further back. All that gray stuff is facet. You see the two little buttocks with a tail above it to the left? Yep, down a little. Right there. See how there's two little butt cheeks? Yep, that's one, and there's the other one. Those are the two facet joints, one on the right, one on the left. Okay, so that is, show us the facet now. That whole facet complex that he's circling, circle a little faster. That whole facet is what I had to get past to get the needle to where it is now. And that's not easy to do. Show us the iliac crest. See the shadow there? It looks like a hill. That is the iliac crest. I had to get past that. I had to get past the facet. And I had to make sure the needle goes exactly where I want it to be at L3-S1. So that's what we've done. Now I need to make sure the patient's awake. I have to get under the nerve root. Show us where the nerve root comes out. The L5 nerve root. Yeah, the L5 nerve root comes out right there. How do you know that? Show us the pedicle of L5. That's the pedicle. He's got the arrow in the middle. Show us the top and bottom. There you go. Pedicle is a piece of bone, and the nerve root comes out just below the pedicle. Right there. All right? So we're well below the nerve root that's exiting, which is the L5 nerve root on the left. Are you comfortable? All right. If I'm too close to the nerve root, she will tell me. You have any pain there? Where is it? Where? I can't hear. Is it in your back or down your leg? Yeah, perfect. So we want it to be in her back. That's actually your L3-S1, by the way. Is that where you typically get pain? All right. Yep. So I'm going to give you some numbing medicine. You're going to feel a little stick and burn. So I want my patient awake for this part of the surgery because I need her help. You're doing great. Just lay still and everything's going to be perfect. Now I called our patient an Okie. Anybody know why people from Oklahoma are called Okies? Because they're from Oklahoma. That's why. But there's a book that popularized the term. Anybody read The Grapes of Wrath by Steinbeck? Yes, no, maybe so. My God, are you serious? Yeah, you read it. We used to have to read it in high school, in literature. Okay, The Grapes of Wrath. If you haven't read it, great book. Anyway, heading towards the L4-5 disc at this point, much easier to get to than the L3-S1. We're using our X-ray machine to guide. Because we're not using epinephrine, we have a little bit of arterial bleeder at the skin. Shot. I'm feeling the facet once again. Shot. Trying to get around the facet at the same time putting pressure on our incision so it doesn't bleed. Getting close, very close. All right, shot. I'm going to have to accept a little bit of bleeding while I navigate. All right, so typically it's a bloodless surgery compared to open back surgery, which you can lose a lot of blood with open back surgery. I'm just going to hold pressure for a second. She has a little bit of small vessel bleeding associated with the incision. The incision is 7 millimeters. Her blood pressure looks good, so it's not a blood pressure issue. And we don't use epinephrine anymore because it tends to raise the blood pressure. But look at that. That's what normal clotting does. Your body has the ability to stop bleeding on its own whenever you have a laceration of a blood vessel, like a little vein or artery. Shot. Now the needle is in a great position. It's low in the foramen, but it's also low at the tear. I want it to be slightly higher, so I'm going to reposition it. There we go. It's perfect. You guys see that? The change in position? All right. No more bleeding because she has normal clotting. Clotting system. We talk about the inflammatory system. We talk about the nerves and neurological, but there's also a hemostasis system or clotting and just basically a stop bleeding system. It involves two things, platelets and clotting factors. Let's give some num-num. Yeah, we're going to give you some more medicine, don't worry. Okay, a little bit of numbing medicine. That was the fascia that she was feeling. So I'll just infiltrate a little more with some Novocaine. Maybe we don't need quite that much for every surgery, you know what I mean?
Yeah.
Start cutting back.
This is very good.
You know what I mean.
Yeah.
Shot. All right, so again, show us the target. That's correct. That's the L3-4 herniation. You can see the bulge there. Show us the bulge. There it is. So we talk about how you really can't see herniations on an x-ray, but you can as long as you have a top quality x-ray like we do at Duke Spine. All right. Huh? You're doing great. Notice how the bulge went away when she took a breath, when she exhaled. So the herniation's coming out more when she inhales and strains, and it gets better when she is not valsalving. All right, shot. Perfect. So at this point, we're ready to test, and we believe she has 3 discs causing her back pain based on where she showed me the pain was coming from based on the MRI findings. And we want to confirm my diagnosis. So we have a L3-S1 disc. Disco.
Oh, it's right here, I got it.
Anybody know what disco is from?
So,
The Zohan. That's right. One of my favorite movies of all time. Don't mess with the Zohan. So we have 3 discs that are being treated today. And we know that from the MRI, she's got small little tears in the annular wall and then a bigger tear at L3-4. Now, how long has she had back pain for? 6 months, we said?
6 to 7 months, she said.
Let's say 7 months. Let's keep it simple. And when I asked her, where is your back pain? This is what she told me. It's right here. Okay? So knowing what I know about the discs and the spine, I knew that she was talking about 3 discs. Are you comfortable? What's that?
Reasonably comfortable.
Reasonably? As comfortable as you can be for being in an operating room, right? All right. How bad is that on a scale of 1 to 10? 10. Is that where you typically get your back pain? Yes. All right, show us the tear. Show us the herniation. Just relax, you're doing great. There's the tear. There's also one out front. Show the front, but that one doesn't cause pain. We're not going to do anything with that. Tears in the front and sides of the disc do not cause pain. They don't cause conscious pain. Maybe subconscious, but not conscious. And honestly, conscious pain is what we're here to fix. Are you better now? You okay? No pain? Cannot inject. Shot? That's too anterior. How bad is that on a scale of 1 to 10?
9.
Is that where you typically get back pain? 9/10 concordant. All right. All right, we're almost done torturing you, I promise. Is that better? Any pain right now? No? No pain? I can't hear her. Little bit. Are you, is that better now? All right. 5-1. I'm really low in the disc, and I cannot see it that well. There. How bad is that on a scale of 1 to 10? 10? Is that where you typically get back pain? I can't hear her. Yeah. All right. Very good. All right. You get to go to sleep. When you wake up, we'll be done with your surgery. I want you to count loud for me from 1 to 100. Count out loud so everybody can hear you. 1 to 100. And don't stop till I tell you. All right. So let's summarize our findings of the test. The patient and I did a virtual visit. She's from Oklahoma. I met her on Zoom with the Duke Spine Institute virtual consultation. And in 10 minutes, we made her diagnosis, what's causing her back pain, looking at her MRI images that she uploaded and sent us, looking at her, seeing where the pain was, her description, and an examination I did through Zoom. So based on the Zoom and the MRI and my experience, I was able to determine that she had 3 discs causing her back pain. Now, the worst ones I thought were the number 3, 4, and 4, 5. It turns out after testing them, the number 3, 4 actually is her worst, 10 out of 10 pain, but L3-S1 is also a 10 out of 10. So that's the worst pain you could possibly have. And both the L3-4 and L3-S1 were 10 out of 10. L4-5 wasn't far behind. It was a 9 out of 10. Okay? So we're going to start fixing these discs one at a time. Show us the dye in the epidural space. You guys see the black line behind the bones right here? See the arrow, Henry? That is dye that's leaked out from the disc, from the tears in the back of the disc. As we inject the dye into the middle of the disc, it leaks out through the tears in the back and goes around the nerves. That just shows you where all the inflammatory juices go. Let's do 5-1 last.
Yeah. Which one? 4 or 5?
3-4 first.
3, 4?
Yep, look at that herniation at 3-4. It's pretty significant. You can see it sticking out back there. We're going to go for that one first. The reason is that I want more room at 5-1 when I get down there. I don't want all these needles in the way. So I want 5-1 is always the hardest. I want to make sure that we set ourselves up for success and not have any interference. We don't want any passing interference. All right, so guide wire is in, needle is out. So far we've lost probably maybe 2 or 3 cc's of blood maximum. That's about 40 drops of blood. And this is a relatively bloodless surgery. Shot? All right, you can see the dilator making its way down through the muscle to the actual disc herniation and annular tear. Clearly see the herniated disc. Shot. Now, we've got some good news. We took delivery of our 2 brand new fluoro machines. Top of the line, best in the world, Siemens. Flow. Flow, right? Oh, this is it. Oh, this is it, guys and gals. We're using it right now. Exciting. So this is one of our 2 new machines. And one of the reasons why Duke Spine Institute is so successful at curing people's pain is that we use the best equipment available in the world that is available for treating the people's pain. And when you use substandard equipment, you're going to get substandard results. So the pictures are pretty amazing, huh? And Jordan's got a big smile on his face underneath his mask. All right. Oh, and I need to show Henry a little video in a minute. So Henry, you got to remind me.
Copy
Can you
that.
hear me?
Yes.
Yeah,
Copy.
don't let me do the next disc without showing you what a percutaneous laser procedure is. Shot?
Copy that.
Okay. Some people want to know, hey, Dr. Duke, what's the difference between the Duke laser disc repair and a percutaneous procedure with a laser? And I'm going to show you. I might as well show you right now. I'll show you one time right now. Bring me the other laser fiber.
The small one, please. Thank you.
Yeah. So a percutaneous, I don't need the whole thing.
No.
A percutaneous, just the end, laser procedure is done by first putting a needle in. And you all saw how easy and quick that was. Then you take the stylet out, you take the fiber, you put it right here inside, don't block the camera. Can you guys see this?
Yes, we can.
You see how I take this 1/2 millimeter fiber and I put it into the needle. We put it down into the disc like that, and I go zap, 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 done. And we're done. That is a percutaneous laser procedure through a needle. Percutaneous means it's done with a needle. Now compare it to what we're about to do endoscopically. There's no comparison. They're 2 totally different surgeries. And I'll show that to you again later without the tube being here. All right, so we're about to start treatment at L3-4. I'm going to bring the endoscope down. And you can see this, right, Henry, how small the incision is? 7 millimeters.
Yes, we can.
Just big enough to fit the 7 millimeter tube that the whole surgery is done through. This is the endoscopic rig. It has a light source, irrigation, a working channel, a camera. I'm going to place this down, and under constant irrigation, I need the scope on. We are now inside the herniation, inside the annular tear. We're right at the deepest part of the annular tear. I went ahead and pushed the herniation back into the disc, so I'm going to take the pieces out now. The blue is the nucleus pulposus that is degenerated from the annular tear.
We have a question.
Sure.
This comes from Jules on YouTube.
Hi, Jules on YouTube. Thanks for typing a question. Welcome to our broadcast, our live stream.
They ask, is she awake for this confirmation of the pain centers?
Great question, Jules. Yes, patients are always awake for the confirmation of the pain generator. We call it a pain generator. That's the proper term. A generator is something that generates or makes. So a pain generator is the source of the pain. It generates pain. So yes, the patient has to be awake for that part of the surgery to confirm the sources of pain or pain generators. Then we put her to sleep right afterwards. So she's asleep right now. She's having nice, sweet dreams. Her husband is here with her watching the surgery. Everybody gets the opportunity to have their surgery broadcast and, of course, recorded, and we give the patient a copy. I want you to pay attention here. Look at this. This is the tear in the annulus on one side. There's the tear on the other. Look at this giant thing right here. This is called the interposed nucleus. It's stuck between the tears, and the tears cannot heal themselves because they got this giant foot in the door, blocking the annulus from repairing itself. That's why the Duke laser disc repair is the only surgery in the world that actually debrides the annular tear, allowing it to heal properly and painlessly. It's all done naturally. I know that you guys think surgery is like, wow, you're sticking a metal tube in her back, but still it's natural. It's a natural procedure, meaning we're not putting any artificial metal or cages, artificial discs, pieces of metal in her spine. We're not doing any of that. There's the tear right there. Can you guys see it? Nicely right there. You see that tear, the blue stuff?
Yes, we do.
So the white is normal, and then the white on the other side is normal. That's the annulus. It used to be connected where the blue stuff is, right in the middle. So this would be a good one for your annular debridement video clip right here, if you want. If you don't have enough, that's perfect right there to include in our video, okay? For the annular debridement part of it. Henry?
Copy that. I was just taking pictures.
Yeah, I'd go back and save this one and include this one. It's a nice one. It's very, very crystal clear. You can easily see the tear. This is a pretty new tear. It's about 6 months old. That's another thing that I can do. I can age your herniations for you. I mean, I can't age them to a specific exact moment in time, but pretty darn close. Usually within a few days, especially if I'm given a history of trauma, I could tell you which event caused it, whether it was pre-existing that trauma. All right, everything's going well. Let's show our audience, how is it that a disc can be so painful? What is it about the injured disc that makes it so painful?
Traumatic injury to the disc can cause annular tears to form. Pressure on the disc causes herniation of the nucleus pulpus through the annular tear. Inflammatory tissues develop within the annular tear, causing back pain. The inflamed annular tear generates pain signals. Additional injuries can cause symptoms to worsen. Inflammation from the annular tear can spread to nearby nerve roots, causing leg pain. Signals travel up nerves to the brain, causing localized back pain. Pain signals reach the primary somatosensory cortex, causing conscious awareness of pain. If you have a herniated or bulging disc and back pain, submit your MRI for a free review at www.mri.dukespine.com.
Welcome back. So you can see from our brief video here that the reason why discs cause so much pain is that it's the tear in the annulus. Not the herniation itself, but it's the tear within the annulus that causes all the pain. And the reason for that is the outer fibers of the annulus, the outer half, has blood supply with arteries and veins and capillaries. So the outer half of the annulus actually exposes the herniation, the nuclear material here, the blue. It gets exposed to the inflammatory system, which lives inside your blood vessels. So the inside of your disc doesn't have blood vessels. Therefore, the nucleus never elicits or creates an inflammatory response from your body. But when there's a tear in the wall and then the nucleus comes out of the tear and sticks its ugly head out, your inflammatory system sees it and says, oh my God. It's kind of like the feeling you get when you see a rat in your house, right? You're like, oh my God, that shouldn't be there. And that's a dirty, filthy animal. I'm sorry for the rat lovers, but that's what I think when I see a rat, if I were to see a rat in my house. And you think that's a dirty, filthy animal, get rid of it, right? Berndes, attack. You go get it. You don't just go, oh, there's a rat, and move on with life. So that's why your body attacks. And look at the pink stuff here. Take it down a notch on the light exposure. All right, this is important. You guys see the pink stuff on the right there of that lump? That is a piece of herniation, an annulus, and that pink stuff is inflammatory tissue. That is why the patient has pain. It's that pink tissue right there. And I'm going to blast it away with the laser right there. Yeah. Well, yeah. All right. That is what we're targeting with the Duke laser disc repair. Again, the only surgery in the world that targets the source of back pain. You know how many cases of fibromyalgia I've seen in the last 20 years? Zero. Fibromyalgia is a diagnosis the doctor gives you when they don't know what the heck's wrong with you. Okay, and unfortunately, I hate to say it, but people don't like when I talk this way, but it's a diagnosis of incompetence. It's truly a diagnosis. It's a diagnosis that the doctor who gave it to you is totally incompetent. That's what fibromyalgia means. When you hear the diagnosis fibromyalgia from a doctor, what they're giving is a diagnosis of themselves as being incompetent. Okay, it's not a diagnosis for you, the patient. It's a diagnosis for them. You like that? There was a book that was written many years ago. I never forget the title. I mean, look this up on Google. I'm pretty sure it's Doctor Treat Thyself or Doctor Diagnose Thyself. I don't remember which of those two. Doctor Heal Thyself. That's what it was. Doctor Heal Thyself, right? And it makes me think doctors sometimes need treatment too. Like, for example, a lot of doctors need psychiatric treatment because they have to accept the fact they don't know everything. And it's really hard for a doctor to accept that. I'll be the first person to tell you I don't know everything in medicine. My God, there's so much I don't know. Like if medicine was 100, I know probably 5% of what there is what you need to know in medicine. But I know enough to do what I do very well. All right, here's another inflammatory area. I want this on the video, okay? Henry?
Copy that.
Get some stills, and are you ready? This is the part I want to record. Ready?
Yep.
Done. See how we blasted it? Got rid of it? I want to show that little segment there. That'll be one of our 5 segments.
Copy
on
that.
the inflammation.
Copy that.
So it's really just a still with a circle around the inflammatory tissue, if you can circle it or arrow it, and then you get the laser just blasting it, getting rid of it. That's getting rid of the pain in the disc. All right. You have other questions?
Yes, we have a question from Jules once more on YouTube.
Uh-huh.
And they asked, what is the wattage of the laser?
Wattage. Jules, the wattage of the laser is 100 watts. And we're using 45. Right, Luis? I'm conferring with the man in charge of the operating rooms, Luis. Do you prefer Dom, Luis, or El Jefe? Luis is the man. He keeps this place running beautifully. Him and his minions. I'm just kidding. We're an egalitarian type of business. We treat everybody equally. When I yell at people, I yell at them equally. I don't protect anyone. You should hear when I yell at myself. Doesn't happen often. But if you think I get on my staff too much, wait till you see what I do to myself.
We have a couple comments and a question.
Sure.
The comments come from Canes25 on YouTube.
Yes, Haynes.
They said, it's amazing this is an amazing out of this world procedure, and it blows my mind every time I see a new one.
Thank you.
Percutaneous is laughable. You better be off letting canes work on you with the nerves dead in both arms.
Yes, thank you. Yeah, you're right. I mean, there's a lot of misinformation out there, and I try to dispel the myth separate it from fact. And the truth is that there's a lot of just not a lack of knowledge and understanding about these procedures and how they work and why we do them. And yeah, percutaneous laser procedures were done for a long time, actually about 20, 30 years ago. And you know, they were done by pain management doctors where you stick a needle in like I showed you, and then you put a laser fiber down, step on the pedal for a few seconds, and you're done. Yeah, late 90s, Dr. Berndes has done his research, late 90s. So we're talking 30 years ago. And it was a popular treatment because it was safe, but it didn't work. And it's got a bad reputation for not working. And so, of course, insurance companies put in their policies, we don't cover it. But it's very different, than the Duke laser disc repair. You can see, I'm not just sticking a needle and putting a laser in there and then just hitting the pedal a few times. I'm guiding my laser, and I'm moving the equipment around, and I'm targeting specific areas that need to be targeted. So the insurance companies like to try to call my procedure percutaneous a laser procedure, but it's not. It's clearly not. It's very different. And that's part of the battle we have to go against the insurance companies to get them to accept this procedure widespread so that people aren't fighting their insurances anymore to get it done. All right, we're just about done, and I've got a little more to clean up over here. Great questions today from the audience. Everything okay?
Yes.
This part I'm working on is lateral. And typically, when you start doing endoscopic surgery, you're only going to look medially. And you got to look 360. You got to look up, down, left, right, front, back. You got to look everywhere, okay? If you want to clean the full tear. Like right here, I'm cleaning tear that's really lateral, meaning it's heading towards the side. Most doctors don't know the anatomy well enough to do that. Here's fibers of the posterior longitudinal ligament, and you can see we're completely through with the herniation. It went through the PLL. That's why we're having to go through the PLL ourselves. Just about done here. Maybe another 30 seconds. We're going to move on to L4-5 next. Go ahead and type up your questions. Happy to answer them for you. Just about done. Cleaning this last bit up.
We have a couple more questions.
Sure.
This next one comes from Oz on YouTube.
Hi, Oz.
And
Welcome.
They ask, is that inflammatory area evidence of acuteness as opposed to chronic?
Yes, that's a great point. Yeah, Oz, great point. So chronic inflammation, it's the more white scar tissue, and the acute inflammation is called granulation tissue. Granulation tissue is acute, recent inflammatory tissue, and that's the pink stuff that you saw. That is a great point. That's the active stuff causing the active pain the patient has today. All right, little antiseptic going in. Betadine made from, or discovered at NASA. NASA is just 10 minutes away from us. We are on the Space Coast of Florida. That's where Duke Spine had its origins. Just 10 minutes from NASA. I used to work at NASA as part-time, taking care of the astronauts during launches and landings. I was part of the emergency medical team as a surgeon. They need a surgeon on the team, anesthesiologist, and a emergency room doctor. And since I trained at Shands Hospital for neurosurgery, I was offered an opportunity to go and participate on these the space shuttle program launches and landings as a member of the emergency medical team for the astronauts. So I would be on site at NASA for the launches at the 3-mile mark, which is the closest you're allowed to be, any human being, except for the astronauts. And at the landings, I would be at the landing strip out there at NASA. Part of the convoy that would head out. You should have seen those convoys. I don't know if there's pictures of the convoys available online, but they're pretty cool. There's about 60, 70 vehicles in the convoy, all have different functions and purposes. There's even a giant fan, the biggest fan in the world, that is supposed to blow the air away from the shuttle if there's a leak of, one of the propellants. It's funny, a giant fan on the back of a truck. It's got to have like literally a 25-foot diameter. All right. Anyway, that's L4. It moved, right? Yeah, the tube must have pulled it out a little. So I need the stylet. We're going to have to put L4, 5 back in a little bit. It's right at the back of the disc, just sitting in the back of the annular tear. I'm going to push it back in. Shot? All right. So we're going to do L4-5 next. That was the 9 out of 10 pain for those of you. Oh, before we do that, actually, you know what? We're going to do the laser fiber on the last one. Henry, don't let me forget. L5-S1, okay?
Copy that. Laser fiber L5-S1.
Yeah, I'll show you just the percutaneous laser procedure at L5-S1. So don't let me forget when I have just one needle left. That way it's not too confusing for the audience.
Copy that.
Or me.
We do have a few questions.
Yeah, give me a second. In the meantime, while I'm doing this, why don't you run our video explaining how the Duke laser disc repair actually fixes people's back pain by debriding the annular tear, debriding the interposed nucleus, and the inflammatory tissue there. Shot?
Disc herniations are a common cause of chronic back pain. The inflamed annular tear causes back pain. Inflammation of the nerve roots causes leg pain. A Band-Aid-sized skin incision is made. A small tube is inserted without damaging the bone or soft tissues. The laser removes the herniation and debrides the annular tear. The annular tear heals on its own. If you have a herniated or bulging disc and back pain, submit your MRI for a free review at www.mri.dukespine.com.
Okay, we're about to get into the L4-5 disc, but I want to show you this, how much pressure is on this disc. Every time I hit the dilator back in, you guys see it popping out? Just literally push it in and it pops out. Push it in and it pops out. That's how much pressure, inflammatory pressure, is in this disc. It's incredible. A massive amount. Shot? So what's happening inside this disc is there's so much inflammation, which, as you know from, if you've ever had arthritis in your knee or hip, you've seen the swelling, right? Your tissues swell. They get swollen. That's edema. Edema means water in your tissue. Shot? Okay? So these people have water in their tissue. In this case, they have water in their disc from all the inflammation, all the arthritis going on in that disc, from injury. It's no wonder why she's having so much pain. You can't really see that on the MRI. You cannot. You just have to know, based on the location of the pain and the appearance, that there's a problem. But you can't see how much pressure there is inside the disc. Okay, that's not normal to have any pressure like that in the disc. That's all from inflammation. The poor thing has been in so much pain, and every time you re-injure your back, you re-herniate, you get more inflammation. All right, get the scope on, please. Laser. All right, at this point, I'll take some questions since we're inside the disc, getting ready to do the L4-5.
These next questions come from Barbara on YouTube.
Hi, Barbara.
They asked, can you tell if this tear was caused by injury or repetitive motion, saying lifting bags of feed? If so, how long ago?
Yeah. So, Barbara, great question. All disc herniations are from trauma. And the mechanism of trauma, there's many different ways to do an injury to your disc. But basically, lifting bags of feed could certainly do it repetitively. But some type of a fall event could have done it. Remember, the tear does not happen at the time your back pain starts. Your back pain starts when the inflammation starts. The inflammation can only happen after you have a herniation. Herniation can only happen after you have a tear. So the tear is always the first step in all back pain from a herniated disc. Trauma causes the tear. What that traumatic event was, there's a million possibilities. You know, going down a slide and landing on your bottom when you were 7 years old, you could traumatize the disc. If the slide wasn't designed properly and it had a 2-foot drop, you could have landed on your butt, and that could blow your disc. That could rupture your annulus, okay? So literally everybody's annular tear history, it doesn't coincide with the onset of pain. People think, okay, I did this and then my pain started. Well, when you did that thing, that wasn't when you got your annular tear. Look at that. Look at that blue stuff. That is under pressure. Okay? That's some normal nucleus right there. That's what normal nucleus looks like. It's white. It doesn't stain blue. But look at all the blue stuff around it. That's abnormal, degenerated nucleus, okay? So I want to try to preserve the normal stuff and just get rid of the blue stuff as much as I can. Anyway, remember, the first step in all disc injuries is annular tear from trauma. That's going to be on our new website. You're going to be able to see what I'm talking about if we launch our new website, which we will. Huh? I don't know. I'm waiting for these guys to finish it. It was supposed to be launched January 1st. Now it's already going on April 1st. The future of spine surgery delayed. Not by me, but my it's funny but not funny. But the truth is, it's taking so long because we're basically putting so much love and attention into it, to be honest. Yeah, of course. And if it's not there, I'm going to add it. I'm going to add it under your profile. Okay? You can put it under your profile. I know, but you can steal it from me. Okay, great. So I want you to pay attention. This is really quite interesting. And Henry, this is a good case to save. Okay? Not for the inflammatory tissue over here, but for the normal nucleus. You guys see it down there? Woo! Like a little cushion. People think the nucleus is like a jelly. It's not. It's firm. It's not hard, but it's, I don't know how to describe it. What's the right word? I don't know. But the blue stuff there used to be like this normal nucleus, and then it got acted on by inflammation, and it turned grungy and bad, degenerated we call it. And when it degenerates, it turns acidic. Not Hasidic like the Hasidic Jews, but acidic like acid-base acidic. The pH less than 7.4 acidic. And when the disc material, the nuclear material, turns acidic, it binds this blue stuff, this blue dye, the Duke spine dye, okay? And when it binds the blue Duke spine dye, you can see it. You can see the acidic, degenerated nuclear material. Pretty cool. Anyway, the reason why this is a keeper is that white stuff, the white nucleus that's normal. You don't often see any normal nuclear material inside a endoscopic disc. You got it, Henry?
Copy that.
And listen, when you do these files, take a few stills. Like get a still of that right there. Get a few stills, because that way when I look at the stills within that file, that folder, I could see what was being highlighted in that case. In this case, it's a normal nucleus pulposus at the center of the disc, still there. Which is why, folks, you don't want to do a fusion. You don't want to do an artificial disc. You don't want to get rid of what's normal and what's left there to perform. Just about done. This is all scar tissue from an old disc injury. Oh yeah, baby. That's beautiful. Nowhere else in the world will you ever see this surgery, folks. Duke Spine Institute. This is the future. Literally, unfortunately, 40 years into the future. You got a window 40 years into the future of what is going to be available everywhere in the world. Maybe 50 years, maybe even 100. Depends on how bad I have to battle the giants to get them to stop putting metal in people's backs and necks and start fixing them endoscopically the way it should be, the way God intended it to be. Hey, I like that. The way God intended it to be. The future of spine surgery today, the way God intended it to be. There's our new motto. I love it. Write that down, Henry. I'm putting that on the damn website, front page, front center.
Can you repeat it?
Are you kidding me, Henry? A moment of, an epiphany moment of great significance.
I'm taking care of the screenshot.
All
You
right,
do everything at once.
The future of spine surgery today, and what did I say? The way God intended it to be. Oh, that wasn't it, was it? Yeah. All right, the way God intended it to be.
I'll replay it later.
All right. We're just having fun. Any questions from our audience?
Yes, a lot.
Thank you.
This. Oh, we also have the percutaneous.
Yes.
Yeah.
Oh, yeah, the percutaneous. You're right.
Yeah.
Let me just set that up. All right, and then I'll get a nice field so you can view everything and get a nice picture of it.
I'm probably gonna need the small latex fiber.
All right, so I'm taking this tube out so you can all see what's happening here. So we're taking the tube that we did the surgery. We're taking this out. And this may be a good shot right here for that comparison. Are you able to see the needle and the tube in the same shot?
Yeah, you can see him.
And maybe what I'll do is I'll just take that off too. How about that?
Perfect.
Good comparison?
Yeah.
All right. So I'm taking this out. Give me a second. I'm going to put some pressure. Don't bring the fluoro in yet. And I'm going to show everybody. This is what it looks like if you're doing a percutaneous laser discectomy. I don't remember the technical term for it, but all right, can you see this?
Yes, we can.
Go ahead and start rolling. Give me a countdown on your roll.
In 3, 2, 1.
Bap, 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 bap. And then done.
Got all that.
All right. That's not the same as a Duke laser disc repair, is it? Not even close. Okay, next, let's bring the floor. That's the past of spine surgery, not the future. And for good reason it's the past, because it doesn't work.
Just like the primal pattern.
Yeah. Save this whole surgery under the special videos.
Copy that.
Okay, almost there, folks. One more to go. L3-S1. We ready? Are we in? Like Flynn, shot? Coming out with the needle. Stay there. Needle is out. Guide wire in. Dilator down the guide wire. Shot. She was a bit more difficult at 5'1" than most people because she has a very high iliac crest. When I came in, it's the first thing Louise said to me is she's got a high iliac crest. I said, I know. I see that. All right, let me think for a moment. Yeah, let's take it out. Shot. Uh-huh. Next comes the tube. And for those of you watching, the whole surgery will be done through this tube. We just redirect it into each disc. So if there's 2 discs we're fixing, we redirect it to 2 discs. If it's 3, we do 3. Impactor. Thank you. Go ahead. All right, so you can look at the x-ray. You see the tube is right there. Uh-huh. That should be good. Let me a little bit. Shot. That should be good. Yeah, we're in. Plenty. Our next surgery is going to be a thoracic
I need that, please.
Duke plasma rhizotomy. Patient has thoracic facet joint pain. He's had a diagnostic medial branch block. He had a rhizotomy done with an RFA, radio frequency ablation. It didn't last. He's had to have it done a couple of times. He said, I don't want any more RFAs. I want a definitive treatment. So we offered the Duke plasma rhizotomy, which we believe is going to be a definitive fix. So he doesn't have to keep coming back. All right, scope on. There we go. Now, some of that is blood. Some of it is inflammatory tissue. The way I can sort it out, let me have the dilator. Actually, yeah, dilator would be good. If I just give it a little pressure, like a little pressure washing, that will get rid of the blood. What's left will be inflammatory. There you go. So what's left is the pink stuff is the inflammatory tissue. All right. Again, we're at L3-S1. Now this disc, originally our patient did not want to treat it. And when I met with her, I knew this was causing pain based on where her pain was localized to. We just tested it, and guess what? 10 out of 10. So definitely it was a cause of her pain. I'm glad she decided to do it. She was only going to do 2 discs at one point, but she decided to get the third one done at the last minute, the 11th hour. And I'm glad she did. But she wanted to meet with me first and see what my opinion was, how bad it was really going to be for her if we didn't fix it. And I felt she'll be back again to have it done if she doesn't do it now. So she chose to get it all done at one time. All right, questions for me?
Yes, we have this next question we have a lot of questions. This next one comes from Canes25 on YouTube.
Sure.
And they asked, did you ever go into action after the astronauts returned from space?
So the question was, did I ever have to go into action, get activated? Was the medical team ever activated when I was on the medical team for the astronauts during the shuttle program? The answer is no. I never did. Thank God. You know, the program was so well designed and executed so well by NASA that I never had to be activated. Obviously, we had some horrible tragedies with the shuttle, but on those circumstances, like Columbia, you know, there's nothing for us to do, obviously, except mourn with the entire nation, and we did. No, you know, I got to be honest with you. Those are some of my fondest memories because I got to hang out with some friends of mine who are also doctors and anesthesiologists, emergency room doctors. We went to NASA. We love NASA. We respect NASA, and we respect the whole program. And we had some fun. We got to hang out with the rest of the medical providers and helicopter pilots and the other specialists that are there. We got to fly around in the helicopter right before launch took place. And we would you'd see all the alligators in the water in the rivers around NASA. There's so many of them, huge alligators, 12 feet, 14 feet, giant ones that nobody ever sees. And it was funny, one of the things I remember is I'm flying around in the helicopter at NASA right before one of the launches, is there's all these spectators that come from around the world. They'd sit on the embankment, on the what is it called? The land that goes across the bridge, you know, like the crossway. And these gators were literally in the water pointing at them in about, 12 feet of water. And you couldn't see them if you were sitting on the embankment. But they were just sitting there pointed right at these spectators in their chaise lounges, drinking beers and waiting for the launch to happen. I thought, my God, if only they knew. You know what I mean? It was a great scene for a movie, right? But no, we never got activated. We honestly just had a lot of fun being there and being ready to go into action. But thank God I never had to do anything with the astronauts. I've got some great pictures in the hallway here of me in my flight suit at some of the activities like the landings. And you can actually see the convoy behind me. We have some of those pictures in the hallways. I miss it. That's for sure.
We have a couple more questions.
Sure. Yeah.
This next one comes from Stanley Ellis on YouTube.
Hi, Stanley on YouTube. Welcome to our live stream at Duke Spine.
They asked, after having TDR in 2005 on my L5 to S1 and one in 2016 on my L5 to L3, and
Jeez.
still in pain, what is there to do? Fusion it all?
Hey, Stanley. Well, first of all, thank you for having the courage to talk to us about what happened. You've had 3 artificial discs done in your lower back, L3, 4, 4, 5, 5, 1. And like so many people who have artificial discs, you're still in pain. That's why I do not recommend that surgery. All right, but to answer your question, what's there to do? We can fix you. I first must make a diagnosis, as I tell everybody. You don't know where your pain's coming from. Right now, I don't know where your pain's coming from, but I have a suspicion. It's coming from your facet joints or your SI joint, sacroiliac joint. You do not need to have a fusion for that, okay? We can fix it with a procedure called a rhizotomy, the Duke plasma rhizotomy. It takes 30 minutes to do, and it's outpatient. and there's no restrictions afterwards. No hospital stay. Literally show up, go to the operating room, takes 15, 20 minutes for me to do the procedure. Total time 30 minutes, 30-minute recovery, and you're out of there and you're back to work and life. I need to make a diagnosis first. To do that, you need to submit your imaging. And go ahead and type up the link that you should use. It's dukespine.com/VC, virtual consult, VC. If you use that link, I'll meet with you and I can diagnose the cause of your pain. And then I could recommend a minimally invasive treatment. You do not need to get a fusion, most likely. Okay? So that's what I'd recommend, Stanley. Come get the right diagnosis and then get the right treatment based on your diagnosis. Great question. Thank you for sharing. And anybody out there thinking about artificial disc, do not do it. This surgery here is the way to go. This is so minimally invasive, and it works to get rid of the pain from the disc every single time. I've never had a failure, 16 years of doing this. That doesn't mean people don't have other causes of pain. They do, like their piriformis muscles or their sacroiliac joint. But the disc pain always goes away. A lot of scar tissue right here from chronic inflammation at L3-S1. Look at the tear right there, the nuclear material. A lot of scar tissue. I'm zapping it with the laser. We're almost done, 5 minutes. Here's the end of the disc right there. Going to clean it up. A lot of scar tissue here from chronic inflammation. Next question.
Next question comes from Oz on YouTube.
Wonderful. Thank you, Oz.
And they ask, if someone has back pain without radicular symptoms and ruling out facet joints, would that mean the pain is only coming from the disc fissure/tear?
Yes, that is correct, Oz. So somebody with back pain, without even looking at your MRI, I can tell you 83% of the time, 83% chance it's coming from a disc. Then when you look at the MRI and you see there is a disc herniation there, you know it is the disc. Once you eliminate the facet joints as the source, which they're the cause of back pain 9% of the patients, according to the research that Arias, my son, has been doing this year, some of the research he's been doing. We have been looking at the cause of back pain in thousands of patients that have come to Duke Spine, and we found that facet pain is 9% of the time in the lower back pain. So once you eliminate the facets, then the chance that it's your disc goes up to 93%. It goes up much higher. I mean, it goes up significantly. Maybe 93 is not the right, may even be higher than that, but it definitely goes up. So yes, you're probably the disc is the cause once you eliminate facet, but it could be your SI joints or your piriformis muscle as well, or your coccyx, your tailbone. That requires me making a diagnosis. Again, use our services to make the diagnosis. Just about done. 10 seconds, maybe. This is the last of the herniation, the furthest back piece. It's very scarred up here. You see how much scar tissue, this white stuff, and calcium deposits there are. Why? Because the closer you get to the surface of the disc, the annular surface, the more blood supply there is. The more blood supply there is, the more inflammation you're going to get. The more inflammation you get, the more pain you get, and the more scar tissue you get from the inflammation. All right, I'm going to take the rest of the questions in the conference room, in the broadcast suite, and type up your questions. I'm happy to answer them for you. I've got 10 seconds left, and I'll be done here. See that last bit of inflammatory tissue there I just zapped? Pretty cool, huh? All right, we're done here. Yeah, let me just take a look. Yeah, there's some fat, the nerve root right there. You guys see the nerve? Oh, it's so cool, the white thing.
Yes,
that is the left L5 nerve root. Beautiful, intact, some fat. You see how we're just below it, but we don't damage the nerve. It's outside the retractor. Beautiful surgery. This is the future of spine surgery you're seeing today. All done. Ah. All right. Henry, you want to show our audience the incision?
Of course.
Irrigation. Can you guys see the incision? How small it is?
Yes, we can.
It's literally 8 millimeters today. I was a little generous. I went from 7 to 8. As we say in the business, I was a bit heavy-handed with the scalpel. All done. So take a look at this incision. Did you forget? All right, I'm going to put a little pressure and then I'm going to show you this thing. And get ready to go ahead and run one of our testimonials. All right, you guys see this? Let me get a ruler. Thank you. Here it is. So, yeah, about 9 millimeters. Can you show this? Very nice.
Yes, we can.
All right, guys, let's put a bandage on it and we're done. I'll come answer your questions. Type them up. Great work, everybody. Thank you for your help. That went very well. Henry, you going to take us away?
Yes.
Let's go. I'm Dr. Ari Duke-Majan at the Duke Spine Institute, here with a patient from Virginia who came out to the Duke Spine Institute yesterday for surgery, and we fixed 2 discs in his lower back. You were having back pain for some time. Do you still have that same back pain?
No.
Gone.
I feel, my back feels 100% this morning. I was able to sleep in the bed, laying flat for the first time in 2 months. I was sleeping on the couch for those 2 months, and I did not get good sleep at all. So I feel great in my back.
Good. Well, that's why we're here. We wanted to cure your back pain and give you quality of life back. What was life like living with that back pain?
Any day you'd be like, it could happen today. I could go down with back pain, severe back pain for a week. And that happened. My first pain started about 5 years ago. I was working in the flower garden. I went down with severe pain. I was down for probably a month that time. And ever since then, it was just like randomly, just out of the blue, I'd go down for another week with severe back pain. It was just no way to live because I knew every day waking up it could happen today.
Yeah, it is no way to live because then you got to be careful every day. You don't set it off. You're worried about it. You're thinking about it. It takes control of your whole life, that back pain. His back pain happened to be coming from 2 discs. And did you see any other doctors? Did they recommend treatment for you in Virginia?
Yes, I was seeing chiropractors for the first number of years. The first chiropractor, he put me on this decompression table, and he would, pull you apart. I did that for 6 weeks. I felt a little relief at first, but it didn't last very long. And I've been seeing just regular chiropractors throughout the years as well. And then when this happened, I saw an ortho doctor. He did not recommend surgery. He recommended physical therapy. He said surgery is like a coin toss. It either works or it doesn't. And that was not good enough for me. I needed a little bit more reassurance that it's going to work. That's when I started looking for other options, and I had a lot of time on my hands. I did a lot of research and I found Dr. Duke here, and I started watching his videos and testimonials. Made up my mind right there. It was without a doubt that was my choice right there. I submitted my MRIs, and within 2 days I did my virtual consultation with you, and 10 days later I'm here.
Yeah.
And it's amazing. I had an appointment with an orthopedic doctor in Charlottesville, and that was February the 2nd for my first visit, just for a consultation. And who knows how long it would have gone after that.
Years.
And yes, I'm done now. It's just I'm back to recovery.
Yeah, the problem is, unfortunately, the vast majority of doctors treating back pain don't know how to cure it. They just don't. And if I had to put a number on it, I'd say 99% do not know how to cure back pain. It really comes down to two things. You have to make the right diagnosis. Where is the pain coming from? Most doctors really don't even know it comes from the disc, and that's where it comes from about 90% of the time. Then the second problem is knowing how to treat it. And the treatment that works, the only treatment that works, is surgery on the herniation, really. And there's two surgeries that work, fusion and the Duke laser disc repair. I've done fusions for years. I've cured people's back pain with spinal fusions, but that's a big, bloody, messy surgery with screws, rods, cages, long recovery. You're on opioid painkillers for months, like 3-6 months, just taking painkillers, just getting over the pain from the surgery. Not the back pain, pain from the surgery. So when we started doing the laser surgery, people weren't having any back pain afterwards. They'd have just a little discomfort for one night. We realized they didn't even need the opioids anymore. So our laser patients don't get any painkillers except Tylenol and usually one or two Robaxin. So you did it. You happy you did it?
I'm very happy.
Yeah. And you can see in the surgery that we did, we actually got into your disc. We used the laser to clean up those tears at L4-5 and L5-S1. Surgery went really well for you. We didn't have any problems. It was just a tiny Band-Aid incision on your back, and that's why you went home an hour later, and that's why you're here today ready to go home. Where are you guys heading back to Virginia?
This afternoon.
Driving?
No,
Flying?
we're flying.
Flying out of Orlando?
Orlando.
Awesome. Anything you want to say to your friends and family and people you know out there?
Yes, living in pain is hard. It's not a way to live. And I recommend Dr. Duke any day.
Well, thank you. I appreciate that. You had faith, and you're going to be rewarded for that. Congratulations.
Thank you.
All right. Good to see you. I'm Dr. Arajik Majan. You just saw me in the operating room talking about the difference between what's being called a percutaneous laser discectomy done through a needle and a skinny little laser fiber where the doctor will put a few bursts of the laser and then that's it. The procedure is done with a needle and a fiber, and that's all. As opposed to the Duke laser disc repair, which is a very sophisticated endoscopic procedure with very advanced equipment and clearly not done with just a needle and a laser fiber. So the Duke laser disc repair was done in this particular patient at L3-4, L4-5, L5-S1 to treat her pain coming from her back. And she traveled from Oklahoma. Obviously, there's nobody in Oklahoma that does this type of surgery. It's too advanced. Be nice if there was, but someday I think there will be. Unfortunately, most spine surgeons today are motivated to do fusions or artificial discs or laminectomies, which eventually become fusions. And the reason for that is those procedures are what they are learning in their training. And just because you learn something in your training doesn't make it right. I hate to use this example. I know I'm going to get some hate mail, but the Nazis and the SS troops learned to kill ethnic people that they hated in their training. So what they learned in their training doesn't make it right. Just because you learned it in your training doesn't mean it's the right thing to do to people. We learn these lessons from history, and there's a lot of badness that could be taught to doctors or other people, and they carry out their mission believing they're doing something good when they're really not. So we have a lot of spine surgeons today in 2023 doing highly invasive surgeries like fusions and artificial discs that put patients' lives at risk and unnecessarily, when we could be doing a very safe endoscopic, minimally invasive treatment. And that's what we're trying to promote to the patients, is that knowledge. We want you, the patient, to know the truth. Okay, and the truth is, these invasive surgeries like laminectomy and discectomy and fusions and artificial discs are completely unnecessary now. They are overkill. They require post-operative painkillers like narcotic opioid painkillers, which are dangerous. We know people are getting addicted to these drugs. We know people are dying from these drugs. The Duke laser disc repair does not use any narcotic painkillers after surgery. Only Tylenol and some Robaxin, which is a muscle relaxer, not narcotics. The Duke laser disc repair is done with a cut that big on your back, even smaller on the neck. And fusions are requiring big, big incisions. Even if they make 3 or 4 smaller incisions, you add them up, it's a big incision. Open back surgeries, they kill your muscle with those surgeries. They're cutting through your muscle. They're killing your muscle. It's called devascularization. They're cutting the blood supply to the muscle off. They're choking. It's like, imagine a country, okay? Like, I don't know. Imagine a country, there is one, I'm trying to think of the name. It's in the Middle East, okay? And there's a big deal right now because they don't have any water. Because like the Tigris River runs through 2 other countries before it gets to them. They have no other source of water. So their neighbors are stealing all the water from the river so that by the time the river gets to their country, they have no water. So basically what I'm getting at is when you cut off the water supply or the blood supply to a tissue, the tissue dies. The country dies without supply of water, okay? So you cannot cut off the flow of water. Water is life. All life requires water. And the blood supply is how your muscles and tissues get nutrients and oxygen. They will die without it. There are a few exceptions, one of them being the inside of a disc, believe it or not. So what I'm getting at is when you have open back surgery, the surgeons are cutting through the blood supply to the muscle. The muscle dies afterwards. And you're left with a back that has dead muscle, which is why those surgeries hurt so bad, which is why people take narcotics. Their muscles are being killed. Believe it or not, it's not the metal that hurts. I could open someone's back right now, cut your back open, put a piece of metal in your back, and you won't feel anything, as long as it's done sterilely, because then there's no bacteria to cause an infection. No infection, no inflammation. No inflammation, no pain. So technically, it's not the metal that causes people's back pain after spine surgery. It's the damage to your body that's causing all the pain. Wake up, people. Your surgeon won't tell you that because, hey, it's part of the surgery and they can't avoid it. But when you have endoscopic Duke laser disc repair, none of the damage to your body happens. That's why there's no pain afterwards. That's why there's no painkillers except Tylenol. So the least invasive surgeries have the least amount of pain, indicating the fact that they're doing the least amount of damage to your body. The Duke laser disc repair is the least damaging surgery when you have back pain and to fix your discs, okay? Then you have complications. Open back surgery has lots of complications. Infections, loose hardware, failure to fuse, adjacent segment disease, pneumonia, heart attack, stroke, death, CSF leak, spinal fluid leaks. Lots of other complications are possible. And your surgeon will discuss those with you. You will see that in your informed consent. And those things do happen. They happen to people. People die from spine surgery. Not mine, but other surgeons, spine surgery, they die. They go to the hospital. They spend weeks and months in the ICU from complications. I've seen it, not with my surgeries, but with other surgeons. So it's very important to understand that all these bad surgeries happening to people, millions of them a year in the United States, fusions, artificial discs, they should not be happening anymore. It is not the standard of care. Okay, but that's what your surgeons are recommending, and that needs to change. It needs to change. We need to demand and expect more from our surgeons, from our doctors treating our back pain. We need to demand a cure. The cures are now available, but they're not available everywhere. Just like aneurysm brain surgeon is not available everywhere. How many of you out there have a neurosurgeon who clips aneurysms living in your town? Very few. They're located in very specific places, academic centers. All right? And you have to travel hundreds of miles to get there, to get a surgeon who can do specialized surgery. Same thing with the Duke laser disc repair and the Duke plasma rhizotomy. You've got to travel, just like this patient traveled from Oklahoma, because she wanted the right surgery for her, the right surgery to get rid of her pain and to make a full recovery and go back to a normal life. And that's why she came to Duke Spine. All right, our questions.
Yes, questions come from Jules.
Hello, Jules.
Once more on YouTube. They asked, was there an unusual amount of swelling and pressure in these tissues, or was this typical for the kind of tissues experienced by the patient?
So Jules, great question. Thank you for asking. Great observation. There was an unusual amount of swelling for sure at the L4-5 disc. Just one out of the three, the middle one. Remember we did the L3-4 first? We didn't see that kind of swelling. Then we did the L4-5, and it was the pressure in the disc was pushing my metal instruments out of the disc. It was saying, get out of here. I mean, that's massive force. If I had to guess, I'd say could be even as high as 30 psi. Okay? It's like basically the tire pressure in your car tire. That's probably how much force was in there. And then the L5-S1 was not really under a lot of pressure, just a little bit. So, great question, and you're bringing up a great point. The pressure was from edema, fluids inside the disc that shouldn't be there. And remember, the disc has a wall around it, so it's going to hold everything in there, kind of like a tire on a car holds the air, right? The annulus holds the nucleus, and the nucleus was what was under pressure. It was under massive pressure because of all the swelling of the tissues. So it's kind of like having air pressure in your tire high, wanting to escape through a hole in your tire. Great question.
Right.
So we decompressed it, by the way. We got the pressure out of the disc.
Next question comes from, Oz once more on YouTube.
Hi, Oz.
They asked, also, what do you think of somatic disorder being the diagnosis for back pain? Any credibility to that?
No. Oz, I do not believe somatic disorder is the diagnosis for back pain. We talked about this either this surgery or the last surgery.
I think it was this.
Oz, the problem is your doctor has a diagnosis. It's called ineptitude, ignorance, incompetence. I mean, there's a few more I won't say just to be respectful of the doctor, but when a doctor does not know the right way to diagnose a problem or treat it, it is the doctor's fault. It is not somatic disorder where what the doctor is saying is the patient's faking it. It's all in their head. That's what they're saying. The problem is that that's what most doctors believe. They believe patients with back pain are faking it. That the patients have something that there is no cause for. Okay? You are a victim of their ignorance. Stop being a victim. Come to Duke Spine Institute. Get fixed. I promise all of you, as sure as the sun rises, someday the medical community of the world, the United States, the rest of the world, will truly understand the causes of back pain. And Duke Spine Institute will be the first to publish that. It is coming. We are going to hit 5,000 patients, and then we're going to publish. We're going to publish the percentages of the common causes of back and neck pain. It is going to be a monumental paper, but it will probably be suppressed by somebody like the insurance companies because they don't want that information out there. All right? But we're going to do our damn best to publish it soon. It'll be done this year. My son, Arias Dukmajian, who's going to Princeton, is actually the key researcher on this project, doing chart analysis. And I already know the results for the first half of the patients, 2,500 patients. 83% of chronic back pain comes from the disc, a disc problem, just like this patient's.
Alright.
Not your mind.
Next question comes from Barbara on YouTube.
Hi, Barb.
Asking, can you tell the age of the tears?
Can I tell the age of the tears? Yes, I can. I can. I mean, not to the exact day, but pretty darn close. For example, if you look back at one of the discs, there was, and just so you understand, this is important. Yes, I told you the tears happen first, but remember, it's not always one tear. It's not always one time. You can have multiple tears, and you can have multiple tears happening, multiple tears occurring in the same tear over time. So you can have an older part of the tear and a newer part of the tear, and you can have multiple tears. So keep that in mind. When I was doing this surgery, I noticed that some of the tears were very fresh. Like within probably 6 months, that's when she had her most recent onset. And those were the tears that did not have much scar tissue. The more scar tissue you see in a tear, the older the tear is. And when you start to get calcified scar tissue with the golden stuff, that really tells you it's much older. Okay? Great questions.
Next question comes from Joshua on YouTube.
Hi, Joshua.
They asked, I'm having a posterior C2 through T2 fusion tomorrow. Is that an outpatient surgery?
Holy God.
I don't know if that's talking about his surgery
Yeah.
or our. Okay.
Yeah, so Joshua, C2 to T2 fusion, okay? I'm seeing more and more of these in patients. I don't do them. I don't think it's necessary to do them. I don't want to interfere with your care. I really don't. But once you have that surgery done, you are scarred for life. And I'm afraid, my friend, that you're going to be in pain for the rest of your life. I would strongly recommend you postpone that surgery. I don't care if you make the surgeon upset. It doesn't matter. If my patients call me and say I'm postponing my surgery, I don't get angry with them. I get it. There's other issues going on in life besides their surgery. Sometimes very important issues, sometimes conflict, sometimes concern, sometimes the patient just isn't mentally or psychologically or physically ready for surgery. It's okay to cancel. Doctors should never be angry with you. When patients want to get a second opinion, that doesn't anger me either. I always welcome them back with arms, or open arms. You know, I respect the fact that these patients want to do an investigation. They want to know what are the other options. They want to explore and learn more. Folks, at the very top of this is something called informed consent. Informed consent means the patient is informed. It doesn't mean the doctor's informed. Unfortunately, some doctors can never be informed, no matter how much time you give them. The fact is, informed consent means the patient's informed. You're informed of the risks of the procedure, the potential benefits of the procedure, and more importantly, the alternatives of the surgery to the procedure or treatment. So it is incumbent upon you, the patient, to do your research. Do not be afraid to cancel your surgery. I'm just telling you, any kind of doctor who gets angry with you because you're canceling your surgery, do not go back to that doctor. That's a bad sign. Okay? Some doctors care more about the money for the procedure, the fact that they're losing income, than they do care about the patient. The patient is the most important thing in medicine. And if the patient is not ready, you don't push the patient ever to do anything. Okay? So take your time, do your research. I would strongly recommend that you do a consultation with me. Look at the link that we're going to type in on the channel right now. It's dukespine.com/VC for virtual consult. Literally get it scheduled. I could do it this week, probably. I hope this week. I think tomorrow maybe if you're lucky. But you're going to have to get your MRI in. Here's why. When they go through the back of your neck, they're going to peel all your muscles off your spine. They're going to kill your muscles. You're going to be in pain the rest of your life. There is absolutely no reason you should ever have a C2 to T2 fusion. Now, C3 to T2, I did a lot of those. Okay? I did 500 of them in my career in 26 years. I'm very good. And yes, C3 to T2, C2 to T2, whatever, we do it outpatient. It takes me an hour and a half. I lose 50 cc's of blood. You go home an hour after your surgery. You recover at home. It is an outpatient procedure at Duke Spine, but we are the only place in the world that does it outpatient. And that's because we don't kill your muscles. We protect them. We keep them alive. They don't bother you afterwards. You have a little spasm and that's it. but these other doctors are going to kill your muscles. I would strongly recommend you cancel that surgery for 2 reasons. Number 1, I don't think you need it. I mean, I haven't seen your MRI. I honestly have no idea what's going on with you. I could be totally wrong. Maybe there's a 1% chance you actually need that surgery. But unless you have a fractured dislocation from a high-speed motor vehicle accident and your spine is barely hanging on by a thread, then you really don't need that surgery. And you'd have to have multiple fractures in multiple places, okay? In 26 years of spine surgery, and I do the most complex spine surgeries, I've never done a C2 to T2. I do C3 to T2, but you never need C2. I've never seen a need for C2. So already the fact your surgeon wants to include C2 in your fusion tells me that they're not a good surgeon and they're not making good choices for you. So I'd recommend getting a second opinion, okay? If you have herniated disc, bulging disc, we can fix it with a laser. You don't need any fusion at all. But I'm seeing more and more spine surgeons doing completely unnecessary, over the top, way more than is necessary surgery. And it makes me sick because yes, they're making more money for it, but their patients are suffering for it. Saddens me.
Right, and last but not least, we got a question from Oz from YouTube once more. And they asked, are you suggesting that open spine surgery, this was late during surgery, are you suggesting that open spine surgery will atrophy the muscles?
Oh my God, Oz, yes. Open spine surgery 100% atrophies the muscles. Your muscles are located in the back of your spine. Whether it's cervical or it's lumbar or thoracic, okay? Here's your spine, here's the front, ACDF for the front, here's the back, PCDF, which is what this patient was just talking about. Do you see these spaces here, this little valley right here? That's where your muscles sit. They literally attach along your entire spine, all the way from your tailbone up to your skull, and they hold your spine up. If you look at the lower back, you can see it too. You see this transverse process here, spinous process? Sitting right in here is a giant muscle called the paraspinal muscle. That's what holds your body up. That's what they're killing, are those muscles when they go through your back, okay? You may know that muscle is filet mignon, because it is filet mignon, in a cat, of course. Unless you part of the Walking Dead series and you eat humans, then it would be filet mignon, human filet mignon. But all jokes aside, that muscle is what's going to be killed with a posterior cervical fusion or a posterior lumbar fusion, okay? And there's a way to do that surgery without killing the muscle. And I figured it out at Duke Spine. You can come to Duke Spine and get it done, but I'm not recommending fusion for anybody.
And that is it.
I hope you enjoyed the surgery, and we'll be back for one last procedure today. This patient injured his back. He's a pilot. He, I can't give too much information, but if you've ever driven on a highway and it says, this highway is patrolled by aircraft, and those aircraft have pilots with radar guns that obviously they work for the sheriff's department or, sheriff's department, highway patrol. They catch you speeding on the highway and you have no idea where it came from. Well, it came from an airplane or a helicopter. And this next patient is law enforcement and had a turbulence episode and injured his spine in multiple places, and we've been fixing him. This latest thing that he needs is he has thoracic facet joint pain. So he has pain in his thoracic spine on the left side. It's coming from injury to the facet joints. We're going to go in and do the Duke plasma rhizotomy, which is a new technology. It's being patented at Duke Spine, and it's going to be the future of facet joint pain treatment. It's going to replace radiofrequency ablation. There's literally 1 million radiofrequency ablations done a year in the United States. It's going to take all those and get rid of them. And they're going to be replaced by this Duke plasma rhizotomy, which actually works much better and gives permanent relief.